speed you can do that. For a head, it takes, and then it's almost done. And starting with the neck. So we can do neck standing up to 3, 4. That's sometimes the maximum. And our full neck scan we do in dorsal recumbency, and it's very important to have a position that your neck lies absolutely straight. And I give you this example first to start with. It's a warm blood stallion with a stiff neck and a grade 2 ataxia after traumatic injury. And you can have a quick look on the radiograph and say, wow, I've spotted it. You can see here some fracture lines here. And together with these fracture lines, you're worried about a fracture. And now just taking the radiographs and making decisions is very difficult, because the owner was willing to do everything we could offer to treat that. And this is the image we got from CT, and this way is multiplanar reconstructions. As you said, you see 3 planes, and then you can nicely compare what you see, and you see the fracture line here, one fracture line here, and you can also see the spinal cord and some soft tissue as well. So this was useful. Based on the CT, we decided not to do any surgery at all and just go conservatively. And after 4 months, this horse was not a tactic anymore and was back to what it was used to. And this is another view of it. You see this oblique thing, so there would be no way to put screws across because that would be very difficult. And you can also use contrast media for CT, but it's always a little bit a decision, because contrast media is a little bit more complicated for recovery if you do it in full general anesthesia. And it also is time consuming in terms of if you plan to do a CT and the surgery afterwards. So on specific occasion, you can do that. And now this is another case, also a warm blood horse, quite a heavy one, which has this obvious luxation traumatic in C3, C4. It was atactic, and it had difficulty to get up in the box. That were the problems of this horse. And when we see these cases now, you never know whether you see sometimes horses like this that they have no clinical signs, and others have. And if you start doing something, you want to be sure that this is the problem, and you don't have any additional problems that possibly are more important for that horse. So this is what it can give you as images. And we also, for this condition, we have a possibility to fuse it and to improve the condition for the horse. But again, you have to be sure it's nothing else. Now, this is a technique we're using for that. It's a system designed by Fabrice Rossignol. And the new thing is it has a spacer in between the 2 vertebrae, and it has this plate with this special titanic screw here on top of that. And this is the approach once the procedure is done. And it's amazing, even if we couldn't correct really the angulation,
Recording in
the
progress.
horse gradually got better. And after half a year, it was not a tactic anymore, and it could get up and down and was starting to be ridden. And this is quite a nice technique. But again, you want to be sure that your indication and your diagnosis is correct. This is another case series we started now since we have the CT, and Aziz was talking about, or Professor Nibar was talking about osteochondrosis, and one of the osteochondrosis thing is also these fragments in the facet joint. You might see here, and the oblique view, you might spot it here. And those cases can be presented to you because they have an intermittent forelimb lameness on the affected side, or they have a stiff neck and riding problems. And if it comes together with an osteochondral fragment, then these are also candidates we can do something for it. But again, you really need a CT scan of the whole spine to make sure that this isolated fragment is the only thing. And that's nice to see how far you can go, even if in a warm blood horse, you can go as far as TH1, TH2 sometimes, but it's all depending on the way you can run your scan. Okay. And then you see these are the fragments, and it's nicely to see this 3D picture here that gives you more of an idea where it is. And we did about 10 cases so far and removed them arthroscopically, but the most difficult ones are the ones that are on a dorsal dorsal-caudal aspect here, and you see there's two types. The one that gets soft here, these are much softer, and the one that have bone-like structure here, like the rest of the bones, are harder. And it's good to know exactly how they lie and where they are, because you pick one up, and then it's also interesting to see in the joint, all the ones we operated, there was some degree of inflammation in that joint. It was not just silent joint. You could see damage in there. And this is with the star, that is this fragment here. And sometimes they are big. It's time consuming and it's a learning curve, but we still try to do it arthroscopically completely, not just in a big incision getting down to the facet joint. And then you also can assess the size of the joint. Good. These are two comments to the neck. And now indications for stifle CT. And as you see, the stifle is a joint that is in the middle of strong muscles that makes it difficult for imaging. But with the large bore CT, we can really have nice scans of all the stifles. And before you do that, you have to make sure that you can localize your lameness to the stifle. And radiography and ultrasonography doesn't really show you completely what's the problem. And you have also know that you can do arthroscopy in the stifle, but you can't see everything in the stifle arthroscopically, just part of it. And therefore, it's a good combination to do arthroscopy and CT. Oops, wrong side, yes. And these are the things we consider when we start. It's definitely good to have a better understanding of the internal condition of the joint if you do a CT. But if you do want to combine it with a surgery, you have to a little bit time consuming, but it's a very useful thing to look at CTs in the stifle, and it's all about the procedure. So far, we couldn't do any CT guided surgeries here. And this is some pictures how we do it. We have it adjacent to our surgery room, and so you can slide it in the gantry. And so far, we were quite successful in doing all the stifles we wanted to do. I don't go over that. Contrast study is something there are people here that could be more sophisticated about this, but this is usually what we get if we do a contrast, and it's amazing what images all can see, because we always wait on their report to find out. They can make comments on the cranial cruciate ligament, on the split in the meniscal ligament, the caudal one. But at the moment, I'm still struggling a little bit whether all what they see is real or it's a real problem. And they list usually a lot of things, but I think we're still in the state that we have to learn to understand what it actually means. But starting with some more simple cases, this was a horse with a fracture of the tuberositas, and then it got gradually more lame and more lame, so we needed to do some information. You are a little bit more secure to place an implant that can fix this implant to the bone and still survives recovery. But this is, I wouldn't do that with just having radiographs. And this is another case, patellar fractures is great cases for CT, because just of these projections like the skyline or the lateral medial view, you can do some obliques. The patella is an awkward bone with a kind of a strange shape. And if you have to make decision conservative or treatment, then it's really nice to have a CT. This is what your 3D picture gives you. This is good to have during your surgery. But more important is you have this multi-planar reconstruction, and to see exactly where these the fracture goes. You have a main component here, you have some comminution here, and you have this gap here, which you can see here. And then you will be able, using arthroscopy to reduce it and to fix it with screws across. And this is the post-operative finding, and this is after 12 weeks, and this horse did well as well. So I only show you cases that do well, forgive me. But I will have others, but not too many with CT, I must say. Cyst is another interesting topic, and what I found, or what I learned, is bone cyst is not like bone cyst, definitely not in the medial condyle. And look at this, this is a straightforward one. The good thing is, if you do CT, you see how big the cyst is, where is it exactly placed. On the also lateromedial is sometimes difficult to see where it is. And is there any comminution with the joint? So that's a straightforward thing, because you could see this on the radiograph as well. And the option we have, if it comes to surgery, is to curate it from the joint, which we stopped doing. We always do with avoiding this and doing transcystic screws, or we're using these titanium balls. And for big cysts, we're using both together to encourage filling. And you can also fill the cyst with something, but it hasn't been decided yet what's the best something for it. So, but anyway, I have decent results with just using screws across. And look at this radiograph. Again, medial condyle here. And it looks awkward. It looks not like a real cyst. So you have an indentation here at some way, and you might see something here. And it was quite an interesting cyst on CT. It looked like to have a column in the middle of the cyst, and like you could run around here within the cyst. This is another view of it. And so if you would center your screws just across here, that might be biomechanically another thing. If you would just do 2 screws on either side of the chamber. That's what we thought. I'm not sure whether this is very important, but you can play a little bit with the positioning of your screws. But this is the most interesting one. It belongs to a student, and as horse was presented as with a 3 out of 4 lameness, which increased the more you work the horse. Can you see anything on this one? Images? I was surprised, but we can go back to radiographs once you see the CT. That's what it looked like inside the condyle. It's the same horse, believe me. And this is just crazy. And we did arthroscopy on this one as well. The cartilage didn't look as bad as you might see from the condyle here. And then what we did in this one, we used more screws, and we tried to focus them on the areas where we had the most of the defects. And then we had the chance to re-scan it a year later, because it was a student horse, and the horse improved dramatically. She could ride the horse again, and we could see some new bone formation in the gaps in there, which was quite rewarding. Yes, and CT is also a good thing to check your surgery, because it's always a critical point here. How far do I go with my screw? And you have to go far enough if there's no bone there to have the effect of lagging it or compressing it. That's the wrong one. This one. Yes. And then this second screw, and this is a difficulty in the CT. All the screws sometimes seem to have a halo around it, and it is difficult to find out whether this is true or not. We could scope this as well, so we couldn't see any damage on the eminence here, but it was just about far enough in the joint without doing any harm to it. So that gives you really black and white what you did. Another interesting case is this large fragment in the caudal aspect of the stifle. And as you can see here, and the 3D picture of that shows you that there are multiple loose fragments here, which belong to the insertion of the caudal cruciate